Hello and welcome. We're glad to see so many of you joining us today to learn about provider relationships and how we can use those provider relationships to help us reduce cost and improve employee health. And so, just to make sure that we've got everybody engaged this morning and ready to learn, before we get started, we're going to put up a poll. And we'd like you to answer the question on the screen. And then we're going to come back to the results here a little bit later in the program. Right, so the question that we're looking for the answer to is, what is your biggest healthcare cost challenge? And you've got 4 different options there. Choose the option that most closely relates to what your biggest healthcare cost challenge is. And as I said, we'll come back to that answer here and allow our panelists to respond to that as our program continues. So thank you so much in advance for your participation in the poll. So as we begin today's program, I want you to think a little bit about the GPS system that you use in your car and how it's changed the way that we travel. If you all recall, before GPS, we had to use paper maps, either TripTiks or even MapQuest, if some of you remember that, with the turn-by-turn instructions. In some cases, like me, I had to rely on my memory or navigate myself with my own sense of direction. Sometimes it worked, but many times we ended up taking a wrong turn and it cost us precious time and additional gas. And so now with real-time GPS, not only can we not take wrong turns, but they can also suggest to us how to avoid traffic or choose the fastest route, just to make sure that we can get to where we're going efficiently and easily. And the groups are even sophisticated enough for systems today that they'll tell you what your estimated time of arrival will be. So again, very different from where we started just a few years back, but it's something that we take for granted now. Back in the day, though, it was certainly a game changer for all of us that were trying to get from A to B. And most of us now, we don't even hesitate to put those directions in when we get in the car to travel. Healthcare can sometimes work in a very similar way as we try to navigate the healthcare landscape. And without the right guidance, employees can end up lost in a maze of ER visits and unnecessary specialist appointments and delayed care, which ultimately can delay time to treatment, but then also drive up cost for the individual as well as the plan. But it doesn't have to be like that. So when you implement a strong primary care strategy, it's like providing a GPS for your employees when they have the opportunity to work with a preferred value provider. You give them the tools to navigate their options and avoid expensive detours and stay on the path to better health. So we're going to talk a little bit about that, how we can manage those topics today and how we can use our healthcare navigation skill sets. So with that, I want to just reintroduce myself. Hello, everyone. I'm Kurt Kubiak, President and CEO of the Alliance, where we help you self-fund smart. And in today's session, we're going to discuss 3 key points. First, we're going to talk about common types of providers and how primary care providers can serve as our quarterbacks for care. Next, we'll talk about why steering and tiering matter and how primary care providers and preferred value providers can work together as the foundation for containing cost. And then finally, we're going to learn how to put that strategy into action by encouraging employees to use primary care and preferred value providers through our benefit plan designs, the incentives that we offer them, and then how we educate. And again, not just educating during open enrollment, but how do we educate throughout the course of the year to remind our employees, how they can be great consumers of healthcare. So again, before we get started, I want to talk through some logistics. This session is going to be interactive, so I really encourage you to please get involved online and remind you to use the chat box to ask questions. And we're going to take as many of those questions at the end as we have time for. And I always enjoy seeing the emoji button. So if there's something that's resonating with you that relates to you, go ahead and give us that feedback. Or if there's something that you take exception to, find a way to let us know that as well. But the emojis are a fun way for us to talk to one another or for us to communicate as the session continues. And then to personalize the service, you can go ahead and access the additional resources on your resource box on your screen. That'll allow you to customize the way that you're seeing us this morning and make it the most usable for you individually. And then a reminder that this event is being recorded and will also be available on our events page of our website and on our YouTube channel. If you haven't already subscribed to our YouTube channel, I'd suggest that you go ahead and do that. That way you won't miss out on any of the events as they become available. But for those of you that are on the event this morning, we're going to also email you a link to all attendees, and you'll know when that recording is then available. And then critically important information for this morning, I want to thank our sponsors. So Delta Dental, National Cooperative RX, and MH Imaging. Thank you so much for your ongoing support. These dedicated and supportive organizations make many of our learning opportunities like this one possible. So please check out how each of these partners can help you in your plan, whether you're self-funded or fully insured at the moment, by clicking on their links in the sponsor box screen. And we sincerely appreciate all of our sponsors' support. It allows us to continue to bring valuable programs like this one to all of our employers and their partners. So thank you for that. Before we jump into the conversation with our panelists, let's take just a minute to level set on a few terms that you may hear throughout today's discussion. So the first I'd like to talk about are provider types. And so primary care is the main category, and within that are a number of subcategories of different types of primary care. First, DPC stands for direct primary care. And direct primary care is a type of primary care provided directly to employers or individuals independently of a health system. And those employers or patients, they pay a flat monthly fee for access to care. So this is similar to what you would experience with a gym membership, for example. And direct primary care is usually accessed through on-site, near-site, or shared site facilities. Next, we've got advanced primary care, or APC, and it's an elevated standard of primary care. APC is going to focus on quality of care and outcomes as opposed to patient volume. So this means physicians can dedicate more time to each patient, making sure that they can effectively manage things like chronic conditions and coordination of care. Then there's the independent primary care groups, IPC. These providers run their own small practices. They can be anywhere from 2 to 20 different providers working collaboratively together. They're not employed, so they can determine how best to take care of their patients' holistic needs, including how much time to spend with each patient and where they want to refer them on for additional care. And speaking of referring on, next is the preferred value providers, or the PVPs, who are the providers that we in the Alliance Network offer that are typically lower cost and frequently utilized shoppable procedures and tests that are impactful to employers' overall healthcare spend. All right, so now with that foundation, let's bring up the results of our opening poll. And again, a reminder, that question was, what is your biggest healthcare cost challenge? And so here we can see chronic disease management by far and away, right? The issue that our listeners today, or our attendees today, are struggling with. So all of the panelists, if you can make note of that, and we're going to make sure that we address that in our answers as we go through the course of our interactions later today. So great insights. Thanks again, everybody, for sharing and participating. Looking forward to addressing these with our providers as we go forward. Now let's go ahead and meet our panelists. So first, I'd like to start with Anthony Brown. Anthony is the CEO at OrthoIllinois. As Chief Executive Officer, he brings a strong commitment to quality, cost-effective care, and improved outcomes. Anthony's leadership continues to drive innovation and excellence in orthopedic care across the Midwest. So welcome, Anthony. Next, we have Julie Lombardo. Julie is the CEO at Capital Physical Therapy and a physical therapist herself. Julie founded Capital Physical Therapy in 2004 to serve her patients rather differently. She holds a Doctor of Physical Therapy degree and advanced board certifications in orthopedics and women's health. Welcome, Julie. And next, we've got Angela Marchant. So Dr. Marchant is a principal and family medicine provider at Tallgrass Osteopathy and is a board-certified family physician and osteopath committed to social justice and holistic healing. She practices in Madison, focusing on integrative medicine, LGBTQ and gender-affirming care, addiction treatment, and osteopathy. And then finally, we've got Christina Wipperfurth Pepper, who is co-owner and chief operating officer at MH Imaging. MH Imaging was founded in 2012 and is an effective option for patients seeking faster access to high-quality, affordable outpatient medical imaging services. Christina has over 20 years experience in medical imaging. And I want to give an extra shout out today to MH Imaging as they are one of our sponsor partners. So thanks again to MH Imaging and Christina for your support there. I want to thank each of our panelists again for being here today and leaving your busy day-to-day activities. Each of you represents a different piece of the healthcare puzzle, and together we can show how coordinated and preferred value care works together. So let's start the discussion today with a scenario. So let's say you're out walking your dog and you take a bad step, you turn your ankle, and it starts to swell. It hurts to even put weight on it. So what do we do next? In what many of us would do traditionally, we might see an urgent care or an ER where you could wait hours with other people that have got maybe more acute issues, or maybe they're there with an illness, right, and a virus or things that you don't care to pick up while you're in the waiting room. And then you ultimately might get referred on someplace else and possibly rack up, much higher expenses and delay your care overall. So that can be typically what happens to us in that scenario. In the scenario of using our preferred value providers in our primary care, your experience could be very different. So I like to think of it as primary care and PVPs, again, as the quarterbacks of your healthcare, and they can evaluate that injury. And if imaging is needed, they can refer you on to where the care is excellent and the cost is low. And if you need orthopedic care or physical therapy, they can steer you to those trusted partners as well, who can also be part of your care team. But the end result is that you get the care that you need faster, less confusion, and significantly lower cost for you and your employer. So again, a win-win. And the big question for many of us then is, what are the biggest barriers to preventing employees from using an independent primary care or a preferred value provider? And how can we overall bend the trend of cost and access for our employees as part of this employer benefit? So Christina, why don't we open it up, the panel discussion with your answer to, what are the things that we can do to make sure that we're seeing the right people and getting the care that we need when we need it?
Right, thank you. I think it all comes down to education, which I know is much more simply said than done. But I think that the biggest barrier is that people just don't understand that it's an option to go other routes than the traditional urgent care scenario. Whereas if they knew that they should or could use a primary care provider practice, and then that PCP practice will know, the fastest way and the most efficient way and highest quality way for them to get their diagnosis and their answers and their care and taken care of much sooner. Likewise, if they just knew that they could call us themselves, if they just wanted to get seen like right away, or they could even just walk in to MH Imaging locations and get an X-ray, within a couple of minutes, and knowing that it's a very acute kind of stat need, our radiologist would read it within a couple of minutes of the exam and they'd have their answers. But I think just the biggest barriers are lack of knowing that those are options.
Yeah, important note that it's a matter of us making certain that we kind of break our old habits of how we were to use healthcare and think of different ways and new ways that we can use. And again, just to be aware, as you said, Christina, of those options. So yeah, wonderful advice. And thank you for clarifying some of the ways that MH Imaging is making healthcare more accessible to your patients already. So well stated.
Hey, Kurt, I'll jump in next. Julie Lombardo with Capital Physical Therapy. I think I would agree with Christina. It's a lack of awareness for folks and just confusion about access pathways. I think the traditional model has been kind of overemphasized by some insurance companies, some employer groups. That's just always what it's been talked about. So lack of awareness. And I think that, for the folks on the in the audience, is understanding it better yourself is the key to getting your employees to make change. I wanted to just add a statistic here. The musculoskeletal world, like we're talking about here, the example of the ankle injury, it's a $400 billion spend per year, and it's the number one driver for about 90% of employers in their costs. And I know the audience really is well versed in that. But I don't think that they know that, 1 in 2 adults suffer a musculoskeletal injury. And from a physical therapy perspective, only 10% of folks get physical therapy care at all. So just being aware of that, I think some of the pain points that they're talking about with things moving from an acute situation where you can get care right away into it turning into a chronic condition where your pains are from the employer group that I'm hearing, that's a huge spend, and really understanding that getting that care quickly and soon after musculoskeletal injury can really bend the cost curve for you. I'll pass the baton to the next person.
Yeah, excellent, Julie. I'm wondering too, if a person is injured and want to get a hold of you directly, how would they do that?
Sure. Thanks. Yes, we are a direct access physical therapy company in the state of Wisconsin. A person can pick up the phone and call, like they can call any one of the providers here on the panel. So, they would just call any one of our offices. It's very easy. We also have a chat function on our website, which is very helpful for folks that are, after hours, after work, at night. And we get those directly, and we get those quickly, and we route those, next day, and people get called very easily, quickly.
Excellent. Yeah, chat now has become another way that we can interact with many different industries. Glad to know that we're doing it here as well. So thank you for that, Julie. It's really, really nice to know how we can access. So next, I want to turn it over to a different line of question here related to specifically our preferred value providers. And so how can our preferred value providers help reduce unnecessary emergency room and specialist visits? So Angela, can you start us out there?
Yeah, absolutely. I can think of a few examples where this exact scenario came up in the last couple of months, where a patient reached out to me as their direct primary care doc about one was an ultimate frisbee injury where their foot was stepped on and they were limping around but still able to walk on it. Another was actually a prospective patient with an employer group who asked, a year ago, she was walking her dog and got bit by another dog on a Sunday night at 7 p.m. and no urgent care was open and she had to go to the ER and get antibiotics. How would that scenario be taken care of in the direct primary care setting? Because direct primary care is built on accessibility and relationship with a primary care doc, my patients, we spend an hour getting to know each other in every single intake. Often there's follow-up visits after that to manage whatever chronic disease is happening or a lot of mental health issues these days. And so I'm really aware of what's going on in my patients' lives. And I'm able to triage. I'm on call for my patients, and I have capacity for that now where I didn't when I worked in the system. And so a patient texts me at 7 p.m. on a Sunday and I see they were bit by a dog, I'm able to respond to that right away and usually get them taken care of. So whether I'm able to get them in the office the next day, or if I need to start antibiotics right away, or if I need to say, you're not able to walk on your foot, or it's not getting better, I'm going to send a script over to MH Imaging, get that x-ray, and then let's follow up in the clinic the next day to figure out a plan. If they need PT, I'll refer right on to my colleagues over at Capital PT or whatever physical therapist group is needed. Or as an osteopath, I am able to provide osteopathic treatment right in the office and get that taken care of right away. So it's just a lot more accessible, and therefore folks are taken care of a lot quicker than within the traditional system.
Excellent. So it sounds like it's important, Angela, to get that baseline set, to get that meeting, that 1 hour visit in place so that from there on out, it's very easy to access you and then for you to refer on to other groups.
Yeah, exactly. And, schedules are schedules. And so sometimes people are busy and they sign on but don't have time or a vacation or what have you to get in. And so I tell everyone, once you're signed on, I'm yours. And so reach out to me if there's an urgent issue. I can easily troubleshoot a sprained ankle. But then we spend that time to get to know each other and really have that foundation. And people are craving that.
Excellent. Yeah, appreciate that. Thank you so much. Anthony, from an orthopedic perspective, how would you envision this, and how can preferred value providers help?
Yeah, thanks, Kurt. I was going to jump in. I think just to tag along on what's said, I know our group and other orthopedic groups throughout Wisconsin and Illinois in the preferred value network, you just think about this differently than a traditional large health system. So, I mean, it really comes down to right care, right setting, and how we organize, our access, how patients funnel in is really aligned with that. So ourselves, as well as other independent orthopedic groups, have urgent orthopedic centers. So ours is called Injury Express. It's a 7-day-a-week operation where patients are injured. They can avoid the ER completely. It avoids that 2 to 3 hour delay, the high cost of care, get them right into an orthopedic specialist who's able to triage and then get them immediately to the right specialist that will be required if it's a surgical intervention. So it really just comes down to finding a preferred value provider who's got the right mindset, right care, right access, trying to minimize unnecessary expense back to the employer.
Excellent. Yeah, access is critically important. We're going to hear that over and over, I think, this morning. And nice to hear that, again, your group has got that 7-day-a-week access covered. Also want to just point out to our audience members that although your name suggests Ortho Illinois, you are also in Southern Wisconsin. Is that correct?
Yeah, I probably should have led with that. That is correct. So we do have locations throughout Wisconsin, Indiana, and Illinois. In Illinois, Ortho Illinois is how it's branded. Ortho Midwest is where you'll find us up in the Wisconsin markets.
Excellent. Thank you, Anthony. So turning over to primary care again, how does utilizing primary care improve outcomes for chronic disease? Specifically, an interest based on the poll that we just took. So really interested to hear this, and clearly our audience is as well. And how does better management of chronic disease contribute to long-term cost savings? So Julie, we know physical therapy can help with arthritis and stroke management and even MS. Do you want to provide your thoughts here?
Yes, I think when people initially think of physical therapy, they kind of think of the standard neck pain, back pain, that sort of thing. But you're right, we treat an awful lot of chronic conditions. It can be a chronic low back pain, it can be MS, it can be Parkinson's disease, it can be arthritis. And, I think PT plays just a really critical role in the management of those individuals. Now, what physical therapy can do for cost savings, and that is if you think about the person with a chronic condition, if they are moving better, in less pain, they will definitely seek fewer other medical appointments. They will seek fewer situations where they're looking for opioids, maybe more expensive imaging, injections, surgeries, that sort of thing. So really caring for that chronic disease affected population is something that we do on a routine basis. And from the employer perspective, I think what's so important about that is if we care for these individuals when they're hurting and we manage it well, they will be moving better, they will be at work more, and they will be more productive at work. And I think those are the important things to take away.
Yeah, wonderful just introduction to how physical therapy is helping to prevent chronic disease or helping to manage chronic disease, which again doesn't necessarily resonate with many of us right away, but clearly you've got an excellent way of impacting those conditions. And so wonderful for us to learn about those services that you offer, Julie. Angela, if you've got something to say there.
Yeah, for sure. To use the example of the sprained ankle or, musculoskeletal injury, which often brings folks into the office, I'm always checking a blood pressure. I'm always double checking if someone's due for a mammogram or a pap test or a colonoscopy. And so even though someone's coming in for an acute issue, my primary care doctor hat is never just isolated to one system. And so with that relationship, studies show that patients who know they have a primary care doctor on their team regardless of if they go in for a visit, their health outcomes are better. Like, they feel cared for, and that is a ton of primary care, is just knowing that they have someone to turn to in the case that something shows up. And so, because I'm able to diagnose that blood pressure before it becomes an issue, or order the mammogram and catch the cancer before it becomes, metastatic, we're able to really prevent a lot. And because I'm able now to get folks in to see me promptly, whereas in the system, when I had 1,300 patients assigned to me working part-time who were very medically and socially complex, I couldn't get people in for months. So they didn't feel cared for. And now I can see the twisted ankle the next day and diagnose the blood pressure and move on from there.
Yeah, that's great to know, Angela. Really good.
As far as chronic disease and how we can help as an independent medical imaging provider, a lot of times chronic disease has to be followed with imaging. For example, MS, people with MS usually get MRIs at a minimum annually, oftentimes every 6 months. So that patient's going to need that imaging on a regular basis. So that's a really important, example of somebody that you can save a lot of money if they know to go to the right place for that imaging.
Yeah, excellent, Christina. That's right. Those follow-up visits make a difference, and making certain that you've got easy access to those and the images are readily accessible to the treating clinician, also critically important. Yeah, many of the employers that I speak to talk about presenteeism, right? And just having people on the job. It's a very tight labor market, and every time they are out of an employee, productivity suffers. And so it's interesting to hear what you all have to say about how do we keep people healthy and on the job. So wondering, next, how do traditional fee-for-service models differ in impact costs versus the value-based payment model? So Anthony, can you talk a little bit about the difference from your perspective?
Yeah, I can, and they're significantly different. So the unfortunate reality is that the majority of healthcare providers, physicians across the country are paid based off of the number of services they provide, not the quality of services that are provided. So it purely is a numbers game, which leads to the rampant overutilization in our healthcare environment. That is shifting. It's been trying to shift with value-based care. There's lots of variants of value-based care. Probably one of the most common variant of that is a bundled episode, which is one set defined price that everyone knows what the price is ahead of time. And that usually applies to a period of time, same day, 30-day, or 90-day. Those are the bundles that we offer. So a patient who may require, say, a hip replacement or a knee replacement, they know up front, this is the one price I will pay. If there's any complication, any problem, additional diagnostic, revision, reoperation, there is no additional charge at that patient, their employer, the insurance company gets charged. So it is changing the paradigm there, where quality is now in the equation. You know what you're getting, and quality element guaranteed price.
Excellent. So what I'm hearing, Anthony, is that many times we experience going to a physician, and particularly with a surgical episode, I'm getting many different bills in the mail over a period of time once I leave that health facility. How does that change then in this episode of care situation that you've just discussed?
It's one set price. So there is one price for all services: surgeon, anesthesia, facility, implant. And then the biggest kicker of that is it with a bundled price is if there's any problem downstream, there's no additional bills that come. And that, as much as we try to minimize complications, they do occur. And so knowing that if there was anything there, that there's a guarantee that one price is all you will pay, there's no additional bills coming your way.
Yeah, what a great peace of mind, right, for us. And again, it's interesting how typically we would buy like this in many other aspects of our lives, but in healthcare, it hasn't been typically the case. So here you're offering, a similar buying experience to, again, other things that we would buy. Let's say we were trying to put a roof on our house. If it doesn't work, you're going to have those folks come back and repair it. You're offering something similar.
Exactly.
Excellent. So again, for the panelists, how do you work with other independent providers? So we've got different independent providers that represent a spectrum of care. How is it that you work with one another? Christina, can you start us off?
Sure. We work with other practices very easily. They know that they can refer their patients to us either with a phone call or with a fax, and faxing over the order or phoning in what it is that they need their patients to have. It's a very quick process. We then get the patient's information and insurance information, and we call the insurance and verify the insurance benefits and determine ahead of time what any copay or coinsurance might be, just so that everybody's prepared and there's no huge shocking bills to follow. And we let the patients know ahead of time what that looks like, and they get scheduled within a few days. They come in, they get their imaging done. We push the images digitally to wherever they should go. So whoever's referred them to us might be an independent practice who has the ability to, who uses their own archiving system. Like oftentimes orthopedic practices will want us to push the images right into their system so that they can view them easily. We have the ability to do that. Some practices want them, via a disc or via a QR code or via a link. However they want them, and whatever their preferences are, we get the images to them. And then we also get the diagnostic report to them with the same day that the patient was imaged. And again, that comes whatever method they want, whether it's a secure email or a portal or a fax, whatever their preferences are. We know that ahead of time, and we get those results delivered same day to the referring doctor. And if the patient wants a copy themselves, they just let us know, and we get them the results themselves as well, same day. So we work very closely. Whatever the doctor wants, we're able to adjust, and we have specific protocols. Like if an orthopedic surgeon wants to see a certain amount of slices in an MRI, which is different from a different specialist, just let us know and we can do that. So yeah, we work hand in hand. We are an extension of their practice, and we know we are a direct reflection of their quality and of their care. So of course we're going to step up and be the best of the best possible.
Yeah, wonderful to hear. Not only can you receive the referral, but then after you take care of your diagnostic imaging component, you're going to be communicating back with that referring provider and getting them the information, so the patient doesn't have to be concerned about that.
Correct.
Yeah, that's a huge benefit.
Yeah, I'd love to jump in here, Kurt. Sorry, I think we collaborate really well with each other. We rely on each other in the community for being other excellent providers and working collaboratively together. I'd love to give this story of how I used this personally with my mother. And if I didn't believe in this route, I obviously wouldn't do that for her. So I do believe in it wholeheartedly. My mom is 80 years old. She had a fall. She fell onto an outstretched arm. She lives out of town. We got her into town. I took a look at her. I knew she had some significant damage to her shoulder. I brought her into an ortho consult, an orthopedic private practice here, got her in right away next day. And they ordered imaging from MH Imaging. I was very impressed. We got her into MH Imaging the next day. It was the total cost of the imaging, the MRI, was $600, $100 of which was her responsibility. Again, I was very impressed with that. They got the imaging results back to the orthopedic surgeon right away. We went back in for a consult. They determined she needed a reverse total shoulder surgery, which was performed a week later. And during that week time, I took her into a DPC, direct primary care provider, in town for a pre-surgical EKG. So Then the surgery was done. She started physical therapy with our group, and she was back home living independently, doing her hair, lifting things into cupboards, caring for her own home independently within a 10-week span. And the speed of which that all occurred was so much better than what it would have been had we waited and gone a different route. There would just have been much more waiting time with getting into an orthopedic consult, getting into an MRI, getting scheduled for surgery, starting her therapy. I think that would have gone months longer, and it was great to have the experience and really be able to kind of practice what we preach. It was an excellent outcome for my mom, and I can't stress that enough for everyone that's listening.
Yeah, what an excellent way to really demonstrate how all of these groups can work collaboratively. And again, for you to trust your family members with the system says a lot about how you support and endorse it. Wonderful.
Yeah, Kurt, just to tag on that just real quickly. I mean, I don't have a whole lot other to add from what Christina and Julie said, but I think one thing that may be a misconception in the minds is with the health information exchange capabilities, it is really seamless and easy to work with upstream and downstream providers, whether they're independent or they're part of the health system. Once a patient comes our way, really easy to access the records, see the diagnostics. We can pull that so the patient doesn't need to fax it or do anything. We can actually grab that information. No redundant tests need to be ordered, no redundant imaging. We can assume the care and carry it forward to the downstream as well. So it's just a great advantage, which I think a lot of people are concerned that they've got to stay in one path so that all is there, but it's really easy with all the exchange capability to pull all the information together and work together.
Yeah, I appreciate those details, right? Again, it's a lot for a patient to have to try to manage if they are responsible and accountable for delivering that information on their own. But for you to, again, to be able to reach out and grab it, for your clinicians to be able to access it and then use that information and not have to redo it, tremendous benefit. And so I appreciate your clarifying that for our audience today. That's excellent, Anthony.
Say, Kurt, let me add one more thing. I think I obviously have the luxury of knowing the players in town and having some relationships and that sort of thing. But if you don't, and you're the employer or you're guiding employees, that's where the quarterback of the primary care provider is really the person that you want to connect the individual to, and they will do that for you.
Excellent. Yeah, thanks, Julie. That's perfect. Angela, along that line, as our primary care representative, how are you helping with this facilitation of working with your colleagues?
For sure. I actually like to think of myself as the coach and drawing up the plays, and then the patient is the QB, tossing the ball wherever they want to go. And patients very quickly learn that going to an independent provider where they can get in quicker because they are primarily taking care of outpatients, whereas the big system is taking care of the sickest of the sick, which is where they need to be, right? They need to be in the big hospital systems, taking care of the chronic diseases with the acute exacerbations. But when my patients figure out, oh, they can get me in, like Julie's story, next week or tomorrow, they're on board from like day one because the experience is so much cleaner. I'd also say that because I have more capacity in this model, I have called plenty of specialists, whether it's ortho or pain management. There's a new direct specialty cardiologist in town, and I've given him a call and he could get a patient in next day for an echocardiogram. So because I can coordinate that care, really communicate the complex needs of patients, because it's never as simple as a knee replacement, right? They've got a whole life and experience and are going through divorce and have chronic pain already or depression or whatever it is. We can really make those difficult times in people's lives a lot easier to navigate.
Yeah, excellent, Angela. Thanks for that. That additional information. It's true. You all are the glue, and it is helpful. I like your take on the patient being the quarterback as well. I think it's an interesting take. Next question, relative to, again, the seamlessness that we can operate, what are the hurdles that you all do see And how do you overcome those challenges? Anthony, if I could start with you, the hurdles that you do see and how do we overcome those?
I think one of the major hurdles is just patients being aware that they have choice. I mean, in today's healthcare ecosystem, there's very large kind of systems, and it's easy to get caught in that model. But patients definitely have the choice on where they receive care. They can shop around to find the best quality, the most cost-effective way to do that. It's actually, when we look how things have changed over the last 10 to 20 years, it has gone from maybe 75% of our patients being guided by their primary and listening to that, where now the vast majority of our patients are actually doing their own research. They're looking at providers, reviews, quality outcomes, and finding ourselves that way. So I think just patients knowing they have the choice and they can choose where they go to receive care, which kind of tags along with the last question we just talked about.
Excellent. Yeah, being your own advocate and learning what you can online, another great opportunity, in addition to, again, using the care access points that we've talked about already today. So thanks, Anthony, for that. Christina.
I would agree. It is a lot about awareness. And also, if a patient is going to a non-PCP or a non-independent, so if they're being seen by somebody at UW or SSM, that provider might not be familiar with MH imaging or the other value providers out there, and so that person who's at one of the systems, that provider might kind of discourage the patient from going to a high value provider for the specialty services. So the patient just needs to be their own advocate and be confident in their ability to make these choices. And and even if they kind of don't want to go against what their doctor's saying and they kind of go along with, I'll get the MRI scheduled. I'll walk down the hall with, Nancy, the scheduler, and get my MRI scheduled. They can call after that experience. They can call MH Imaging and say, hey, my doctor at UW ordered, whatever. I'd rather come to MH Imaging. And our answer is no problem. We'll call over to that doctor and we'll let them know we have a mutual patient, and can you please fax the order over here? And they do that. So yeah, I guess some of the hurdles are if a patient's being seen by a system doctor who's unaware of the quality options out there outside of their systems.
Excellent. I appreciate that. And again, trying to keep pace here with some of the questions and answers. I'm going to keep moving along. Last question I've got here for the panel. Again, relative to access, if you're easy to access, are you a quality provider? And why is it that I have to wait in the health systems, but I don't have to wait to see you? Julie, do you want to start us off there? Angela.
Sure. It looks like Julie might have lost her sound. Like I said, in the system, I had 1,300 patients assigned to me working 3 days a week, whereas here I have about 220 right now. And so we say in the DPC world, 1 to 2% of our patients reach out for a visit per day per week. So I'm expecting to see about 10 to 20 people per week, which if I'm seeing 20 a week, that's how many I saw in a day in the system. So I'm able to spend a lot more time with folks because of that. Also, I'm not incentivized to bring people in for visits, right? In the fee-for-service model, in traditional insurance-based models, you're incentivized to bring folks in because that's how you get paid. Whereas here, I'm paid to keep people well. And a lot of issues, I used to work in an urgent care, but from what I saw, about 80% of those visits didn't need to happen if they could actually get in touch with a doc who can triage the issue and take care of them. Whether it's a rash, send me a picture, right? And so I'm able to carve out time to really respond to folks in real time, and therefore not even need to bring them in, saving the time on work, saving the time from sitting in an urgent care for hours on end to see someone who doesn't know you.
Yeah, so you've created the environment where you can see people more quickly. And so it is quality care, it's timely care, it's easy to access. And so wonderful to learn more about that. Thank you for that insight. So again, we've discussed the benefits of using primary care and preferred value providers. But again, if you can't get access to them, well, that is a challenge. And so I want to encourage employees to use primary care, and that starts with your benefit plan design. And so some of the changes that we made here at the Alliance have to do with steering and tiering. And we went from a high deductible health plan with an HSA, which we still offer, to offering a copay model that includes different tiers. So how the copay model works is that if an employee chooses providers in tier 1 of the plan, they would have a $0 out of pocket. And if they choose a provider in tier 2, they'd pay their own portion starting at about $50 out of pocket, and then so on going up the tiers. So tiering still gives that employee choice, but if they choose tier 1 providers, they have no additional cost. And the plan also pays a lower cost. So it's a win-win. And the providers in tier 1 are our preferred value providers. So once a patient visits them, if they need a follow-up issue like an imaging or therapy or surgery, right, those further experiences are also, cost sensitive and access sensitive. So the cycle of saving continues for both the employee and the employer. Some of the lessons that we've learned implementing this type of a steering and tiering program and the PVP strategy are simple, but sometimes they're overlooked. For example, make sure your benefit plan design encourages people to the appropriate sites of care. Make sure that an ER visit, for example, has a more expensive copay than an office visit to encourage employees to choose the office visit first. And if you're not ready to jump into steering and tiering just yet, which many of you may not, you can still use incentives like cash rewards outside of the benefit plan for an employee to choose to seek care from specific providers like a preferred value provider. So any additional commentary from our panelists there?
I will say that more and more we're getting referrals and patients are very aware of that. No, if I come to MH Imaging, I have zero copay. Like they're very aware of that. So wherever they're employed, their employer is doing a very good job of educating them about their options within the plan design, and it's working. They're definitely interested in that $0 copay for an MRI or CT or X-ray, ultrasound, echocardiogram, whatever it might be.
Excellent. So there are ways that we can, again, educate and encourage employees to make different choices than they would otherwise make. So again, what an excellent way for us to just get educated on some of the features of the clinicians that we've got on our panel today. And so what I'd like to do is to just quickly wrap up what I've got for takeaways and get to audience questions. So again, very quickly, the use of primary care and preferred value providers as a quarterback for coordinating other provider care is key. Secondly, that preferred value provider group is a cost-saving strategy, not just a benefit in the benefit plan. And that you've got to design those plans, thirdly, to encourage employees to use primary care and preferred value providers and educate them on how to use them effectively. It's critical for success. Finally, just want to make a quick note that we'd love to see you in person at our regional events later this month. We'll be taking a deep dive into benefit plan design. So join us for one of these half-day workshops where we're going to be on site in Wausau, Eau Claire, or Milwaukee. And you can get all the details about these or other events via our events page. So we've got time for just a few questions. I want to thank everyone who took the time to submit your questions in advance. And if there's something that resonated with you, please go ahead and get us those questions. So the first one that I see came from Susan at Transbridge. And the question is, how can tools and resources be made available when employees need them? We can educate often, but the employees will generally be off-site when a need for care arises. Who would like to take that one?
I can chime in on that. When I have worked with employer groups and they're new to self-funding or they're new to DPC. Some small businesses like to start with DPC as a benefit before they even are required to provide insurance. I go and I meet with the employees at the office. And I did a visit like this yesterday, and offsite employees were virtual, right? And so starting with that relationship and being that quarterback or coach, I think is really key, because folks are thinking not necessarily of work if it's not a work-related injury. When they're struggling with a health issue, they're thinking of their primary. And so I really like to be actively involved in helping folks navigate and reach for those tools. And if I'm able to work closely with an employee and understand their specific benefit plan, then I'm able to guide folks to where they need to go.
Yeah, so it's interesting right now. So not only just understanding what their healthcare needs are, but also understanding what their health benefit plans is and how do you work with them to make sure that they get to where they can go most efficiently. That's, again, taking it to the next level. I really appreciate that. Excellent response. Next question I've got is from Kyle at Spuncast. And so he asks, how do we control the costs of healthcare, and how can we steer our employees better to encourage these better habits and achieve lower costs? Anthony, could you answer that one?
Yeah, I can. And it may be a little bit of the previous question as well. I mean, we work with a lot of self-funded employers who have that similar concern, and just observing what some of them are doing that works really well to control the costs, steer their employees, and then also educate when their employees actually need care. I think it really comes down to, you can't over communicate enough. I mean, open enrollment is not enough. It happens once a year, and employees quickly forget, who are the preferred providers, where do they have zero copay, zero deductible, where the employer is trying to steer them. And so in putting, flyers, communication in break rooms. I mean, I have one employer who puts it in the bathroom stall, the preferred providers where they have zero copay and deductibles. That works really well. Monthly newsletters. Just the more you get that out there, because the reality is you never know when your employees will need care. And the more that's out there, there's more awareness. And it really comes down to that and the tiering, because when they have zero copay, zero deductible, that definitely aligns them to the providers where you'll have the best cost savings opportunity, and your employees will get the best experience as well.
Yeah, so I'm hearing multifaceted approach. Don't rely on just a newsletter or just a once a year communication. Find ways to get to the employees where they are, in the break rooms, in the restrooms where they're captive, and sending mailers home, I've heard, also is an effective way to get the spouse involved, right? Who might be the person making those decisions about where healthcare is consumed.
Exactly.
Excellent. So next question I've got is, what is the first step a self-funded employer should take if they want to improve their benefit plan strategy to include preferred value providers? Christina, could you start us off there?
I would think the first step would be asking you, Kurt, and meeting with. I mean, the way I see it, the very important thing is to have primary or DPC, direct primary care, because these folks are excellent providers, and they know how to, they're the GPS that you opened up this session with. They know how to navigate for best quality and best outcomes, et cetera. So they should, meet the different DPC providers in town and see who, or maybe they have multiple DPC options. But I think that's where they need to start, is interviewing the different DPC options would be my approach.
Yeah, so kind of where we started with the DPC as the quarterback, make sure that your benefit plan design is encouraging those behaviors. Next question I've got is, how can employers gauge the success of using a preferred value provider strategy? What's the easiest way to measure cost savings? Anthony, do you have an answer to that one?
Yeah, I do. I mean, ourselves, we're a large employer, self-funded. How we do it and how I've seen other employers is just keeping an eye on the main buckets of spend that you have from your employees. Is was said earlier, musculoskeletal is usually top of the list. Cardiology, oncology, there's usually a couple of big ones there. But the more that you can incorporate, preferred providers and steer your employees to the higher quality, lower cost settings, just comparing that year over year, you should be able to see that savings. I mean, we do have ability where we can help employers if they want to see, based off of CP history, what would it look like if they had their employees come to us versus maybe a traditional health system, to look what that looks like. And anecdotally, it's usually 50 to 60% less going to an independent provider than going to a large academic or integrated health system. So it's keeping an eye on those cost reports, which are easy to get access to.
Yeah, so looking at the largest spend items in your claims, figuring out where you can make a difference, and then measuring those costs and working with your account advisor, your benefits advisor, to make sure that you can quantify those savings. Am I hearing that right?
That's correct. Yep.
Yeah, excellent. So next question, interesting for a lot of us, employers that are located outside of the city. So are there examples of how employers in more rural areas have increased the use of preferred value providers? Angela, can you talk about how the rural folks could get access to these specialists?
Yeah, when you're not incentivized for visits, a lot can be managed virtually. And, the pandemic really did kind of propel us all in healthcare to offer virtual options. Now, you can't do an X-ray virtually, right? But I can take care of a lot by phone, by text, by email. And because everything's directly with me, I don't really need to bring in patients. Even a blood pressure cuff can go home with someone, or they can pick one up at the pharmacy, right? And so, in the primary care setting, we can really work collaboratively with folks farther out. And I do have patients come to see me, even though I'm in Madison, from all over. I will say also that when I know a patient's insurance policy, whether it's self-funded or through the marketplace or they're uninsured, I'm going to be referring as much as I can to independent providers. And so as the coach, we can really guide folks that way.
Excellent. So yeah, we didn't talk a lot about telemedicine, but certainly that is an option that became very popular during the pandemic and then has now continued on. And I think the quality of those interactions has actually improved. Is that true, Angela?
Yeah, absolutely. And, I meet patients where they're at. And so I have within my EMR ability to have video visits. But sometimes, I had a patient text me, hey, I sliced my finger on the garden shears. Do I need stitches? And we jumped on FaceTime. She was literally still out in the garden. And so we just video chatted that way. It was easy for her to jump on, and we took care of it. And I didn't, she didn't need stitches, and we just did some glue at home, and she kept on gardening. So there's a lot of ways we can really meet folks. Again, because I'm not incentivized to bring someone in. I'm just there to do the best for them. And I'll add that, there's growing frustration amongst specialists around the country. I was recently connecting with a direct specialty endocrinologist. Endocrinology can be managed virtually. And so I can order the labs, I can send them on to her. She's licensed now in Wisconsin. And so I'm starting to send people to her because she can get people in quicker. So the tide has really turned in the medical community because the system generally isn't serving most people and most docs.
Yeah, super practical solutions, Angela, that you mentioned, and the fact that there are more and more providers coming on to the independent space and that there are more and more solutions that you can access is critically important to know. So thank you for that insight. All right, so that wraps up today's event. I want to thank our panelists again for joining us today. I appreciate taking the time to share your insights. Always helpful to get the perspective of those that have got that day-to-day working relationship with the patient, right, and provide such in-depth knowledge. If you'd like to have any additional support of any of the content that we've discussed today, please reach out to your Alliance account executive. We've got experience in benefit plan design. We're happy to assist you. Or if you're not a member yet, or you're looking into becoming self-insured, feel free to reach out to our business development team using the QR code or the URL code on your screen. And if you're watching this webinar live, you can claim CE credit by clicking on the View Certificate buttons on your screen, or on the Engagement Tools drop-down box at the top right-hand corner of your screen. So all of you advisors, please remember to sign the attendance form. And then finally, we'd love to see you at our in-person regional events later this month. We're going to be taking a deep dive into benefit plan design. So join us again for one of these half-day workshops in Wausau, Eau Claire, or Milwaukee. You can get all the details about these and other events via our events page. And again, thank you for joining us today. Remember, when you think of the Alliance, think of self-funding smart. Take care.